Good morning, everyone. And today, this is the last lecture about neurology. And in this one, we are going to discuss myopathies. Again, I will show you this thing, and why I'm showing you this thing because in the previous lecture, I was talking about how we move around the condition. So see, I talk about one condition which was motor neuron disease, in which the problem is in the um, you can say the anterior horn cells and how they present. It's a motor neuron disease, so there is no sensory symptoms, and there is generalized wasting, fasciculation, and weakness of the muscles. Then we discuss about the peripheral neuropathies and how they present as distal wasting and weakness of the muscles, legs more involved than arms. Why? Because the long nerves are in the lower limbs, not like as compared to the upper limbs, and bulbar involvement is very rare, and sensory symptoms are also there, right? In the previous lecture, we were talking about myasthenia gravis, which is the disease of the neuromuscular junction, in which there is muscle waste weakness without wasting, and the weakness varies according to the disease. Like myasthenia gravis, I talk about. In that one, there is weakness on repeated stimulation. Ocular and bulbar muscles are commonly involved. They respond well to treatment. Now, our last topic is myopathies or the muscle diseases, in which you can see the X, the problem is in the muscle. So, muscle weakness and wasting, the distribution of which depends on the type of the disease, but with a strong tendency to involve proximal muscles, that is, trunk and limb girdles. Now, basically, muscle diseases or myopathies, these disorders can be structural or can be functional, and these can be differentiated from other diseases of the motor unit. For example, what I'm talking about, we can differentiate them from motor neuron disease or myasthenia gravis by clinical and laboratory findings. And these diseases are basically rare diseases. Now, the pathology is in the muscle itself, so there will be muscle weakness and wasting, and the pathology is in the muscles, right? Now, if I will classify myopathies, for example, so what uh, they are different type of myopathies. Like there could be inflammatory type, there could be endocrinal conditions or endocrine conditions which can affect the muscles. There could be toxic conditions which can affect the muscles, as well as there could be infections and infectious conditions. There could be hereditary causes, hereditary, like which we acquire. So hereditary can be hereditary dystrophy or hereditary metabolic, like some metabolic conditions, or you can say hereditary metabolic conditions can be there. Um, there could be hereditary mitochondrial problems, and so there are different things. So you can say hereditary can be hereditary dystrophy. uh, Hereditary could be hereditary metabolic mitochondrial, or one thing called as hereditary periodic paralysis. Now, see, inflammatory causes I will talk about. Uh, Two of the conditions which are very important in this one. There are many, by the way. For example, sarcoidosis, they affect the muscles. Like two conditions which you will study in detail in rheumatology. One is called as polymyositis, and one is called as dermatomyositis, and there is one disease called as inclusion body myositis. So simply there is some sort of inflammation going on in the muscles. There are many endocrinal conditions like thyroid, hypothyroidism, hyperthyroidism, Cushing syndrome. All this one, they affect the muscles and the proximal muscles of the body. When I say proximal, it means the muscles around your shoulder and the muscles around your hip. Toxic. Many medications affect the muscles, like um, steroids, statins, like or the cholesterol lowering drugs, antiretroviral drugs, cyclosporin, and alcohol, cocaine, heroin. Like there are many, many, many toxic things which affect the muscles. Many of the bacterial, viral, as well as parasitic infection give muscle problems, muscle inflammations, or myalgias, pain in the muscle. In this lecture, we are going to study hereditary dystrophy, like the Beckers one, the Duchenne one, and there is Myotonic dystrophica. And then there could be metabolic hereditary problems like McArdle's disease. And then there could be hereditary mitochondrial disease. For example, one is called as MERF, MERRF, and one is called as MELAS, MELAS. So, and then there is hereditary periodic paralysis, in which like it's a sort of a some channel problem of potassium, by the way. So, like what I want mean to say, like there are many type of myopathies or many conditions which can cause myopathies. So, 21-year-old female patient, progressive generalized weakness for 8 years. Now, see, like it's a long history. The patient began to notice weakness in the hips and increasing difficulty in rising 8 years ago. 6 months later, the weakness advanced to the knees, and she could arise only by climbing up her legs. 12 months later, she felt extreme weakness in her shoulders and upper arms, so that she gradually became unable to comb her hair or even lift her arms to shoulder level. Now, what is this case for? Is of like when I will finish my lecture, I think you will be able to answer this thing. Now, this is the same case going on. Difficulty of locomotion slowly became more pronounced until at the time of admission. There were never any symptoms of tremor, spasticity, sensory, or sphincter disturbances. So, see, all the symptoms are showing what? Like when there are no symptoms of tremor, spasticity, sensory, or sphincter disturbances, like it means like the CNS is normal, the PNS is normal. No history of similar disease in her family, so it is some sort of acquired one, right? And on examination, like, marked atrophy of the shortal girdle, you can see, like, you can clearly see her scapulas and see her thighs looks like wasted, and tendon reflexes are decreased bilaterally, and no impaired superficial and deep sensations which were normal, and CK, creatine kinase, which is present in the muscles, it is very, very, very highly raised. So anyhow, this is the case. Now, this is a general introduction about all these things, right? They affect all the ages, complex pathogenesis are there, and new diseases to be identified. So things like this, and common manifestations are weakness, atrophy, pseudo hypertrophy. I will explain you this thing. Myalgias or muscle pains and cramps and fatigability. Now, like they are telling this in this slide, like what is the presence of the myopathic weakness, like ocular palsy can be there, bifacial weakness or palsy can be there, bulbar palsy can be there, and how we can see, like, of course, bifacial palsy, or we can just simply say facial palsy. You can ask them to smile, expose the teeth, close the eyes, and bulbar palsy, dysphagia, dysphonia, dysarthria. Cervical palsy, hold the head erect and lift the head from the pillow. So this is like just the examinations point, like to check the weakness, where is the weakness, and there could be weakness of the respiratory and trunk muscles. And to check the brachial arm, like You have to examine the hands, arms, and shoulder. And by crural palsy, you have to check the ability to walk. Limb-girdle palsy, inability to raise the arms or raise from squatting, kneeling, or sitting position. Simply to check the proximal muscles are involved or not. So what we ask the patient to comb the hairs, So when we comb the hairs, basically your shoulder muscles are the one which are playing the role. And we ask the patient, to uh, put their hands in front of the chest, like so that they should not use their hands to get up from the chair and try to get up from the chair. So when someone have weakness around the hip joint in the proximal lower muscle, so they cannot get up. So distal bilateral limb palsy, there could be foot drop, and general paralysis can be there. So anyhow, like these are the general things which we can do for examine them. So I'm just discussing, like I'm not talking about any condition right now. Generally, I'm discussing the thing. So you can see over here the wasting of the muscles, and here you can see the pseudo hypertrophy. And whenever they have myalgia or cramp, so they could be spontaneous, they could be symmetrical, they will be symmetrical, both mostly in the proximal muscles. And you have to take the history of pain, what is the character, site, radiation, all the stuff, plus the medication history. Like statins, I told you, is one of the drug which causes myopathies. Now, these are the common myopathies. And if you will see over here, there could be muscular dystrophies, there could be inflammatory dystrophies. I already told you one of the things, so this is like the same classification, okay, given over here. Now guys, I would like to discuss the progressive muscular dystrophies. They are progressive, right? And if you will see over here, of course, when there is progressive muscular dystrophy, so there is no effective treatment available, and there will be muscle degeneration. And these are the muscular dystrophies. You can see like some of them, they are X-linked, like Duchenne's muscular dystrophy. So basically this one is X-linked recessive condition. X-linked recessive. Then there can be Becker's muscular dystrophy. We will discuss these two in detail. Emery Derifer's muscular dystrophy, not so important. Then there could be some autosomal dominant conditions like facioscapulohumeral muscular dystrophy. As the name shows, face, scapula, and humerus region, they will involve, again, autosomal dominant condition. One condition which we are going to study is myotonic dystrophica. It is also autosomal dominant. Then there could be distal muscular dystrophy, oculopharyngeal muscular dystrophy, congenital muscular dystrophy, and then there are some autosomal recessive conditions over here. Limb-girdle muscular dystrophy or congenital muscular dystrophy. So anyhow, now again, this is like maybe too much for you guys, but the thing is easy, not so hard. Rather, what they are showing over here is extracellular matrix, right? And what they are showing here is the muscle. You can see the actin, the myosin, like the things which you know, right? And if you will pay attention, this is a very, very, very nice diagram, you can say, in which, like, for example, they're talking over here, dystrophin protein. So down it is written over here, Duchenne's and Becker's muscular dystrophy, they occur due to problem here. Of course, the gene which is making this one. Or Emery Dreyfus muscular dystrophy or X-linked Emery dystrophy. Anyhow, we are concerned with this one. So remember dystrophin. Okay. Then we are we will also discuss like some others one. Okay. And of course, like this one is given in too much detail, and they're talking about very, very like too much muscular dystrophies, like nemaline myopathy or things like this. So of course, we are not going to discuss all this one. They're not important. So now the important thing over here is muscular dystrophy. Remember, guys, like there is some pathology in the muscle. So there is muscular degeneration going on, like progressive muscular necrosis going on. There will be increase in CK. I told you, creatine kinase and LDH. LDH is present practically in every cell of the body. And due to the muscles, they are not normal, so there will be fat infiltration over time in the muscle. Basically, that is the thing which causes pseudo hypertrophy. And there is limited regeneration of the myofibers or the muscle fibers. So you can see over here, they are showing the histology of the normal muscle, and they are showing the degeneration and regeneration, or like the abnormal muscles. Now let's start talking about Duchenne's and Becker's muscular dystrophy. Okay, so now the important thing to the important points, you can say, which we have to remember, because most of these Duchenne's and Becker's things, like are asked in MCQs. And when I say MCQs, like I'm talking about the exams point of view, like AMC and like USMLE exams like this or PLAB. As I told you, like this one is X-linked recessive, right? Basically, Duchenne is the most serious inherited muscular dystrophy, guys. The most common and severe. Okay. Now, as it is X-linked recessive, and if you know how the X-linked recessive things they pass on, so we need two abnormal genes, one from the father, one from the mother. And as the male makeup is XY and the female is XX, so this is basically the healthy female carriers when they marry someone who is the affected person or who is the child of an affected male person. So now what happens is they have a gene defect in the dystrophin gene and they have lack of dystrophin. Now this is a very important point. This condition is severe, so this condition have lack, is absent dystrophin gene. Okay. Now you can see over here. Okay, this is like they are showing, the normal one, like the Beckers, the Duchenne, and the carrier, how they looks like. But see, this thing is lacking. Okay. So now, of course, only boys can get affected because this one is X-linked recessive. The affected boys, they usually show the muscular weakness before the age of 5. So see, from 2 to 5 years of age. And they die because of muscle weakness. Their muscles become so weak that they cannot breathe properly. They get multiple chest infections, as well as they develop cardiomyopathy in the late teenage life. So what happens, guys, in this one? The signs in the early life, there is weakness in their proximal muscles. And what it do, there is very important thing, something called as Gower sign. You will write it on the YouTube and you can see a video, but I will tell you here. Their muscles become so weak that when they want to get up from this position, they climb up their own body. They use their, see, this boy is using his hands to support his body weight. So they climb up when rising from the floor to the standing position. And you can see they have muscle wasting, maybe not evident in this one, but for example, in this one, they have muscle wasting together with pseudo hypertrophy. So what happens? There is fat deposition over here. Okay, so I think I explained all these things, right? So this is the Gower side. See, he is climbing up his body. Now, the affected boys, remember I'm using the word boys, X-linked recessive, they have elevated creatine kinase as well as CK levels in their blood. So, you know, like in the carrier state, like the females, when they're the carriers, they have some elevation in the enzymes, the muscle enzyme CK, but they are generally normal. Okay, so basically it's X-linked on the X chromosome. There is Duchenne. There is a gene which is responsible for making this dystrophin. So that one is absent. So there is no dystrophin. So of course we can do EMGs, electromyography, in which, like, of course we will get low amplitude results. If there is cardiomyopathy, we can get EKG or ECG abnormalities, and we can see do the biopsy, in which we see muscular degeneration, like this one, Okay, so we can take the family history, we can check the clinical presentation, Gower signs, pseudo hypertrophy, wasting. We can check the enzymes, CKLDH, we can do EMGs, we can do biopsies. The diagnosis will be made on this thing, guys, genetic testing. Molecular genetic diagnosis, simply what will happen that this gene will be absent. Okay. Now, this is called as Duchenne's. Remember, from D for Duchenne's and D for dangerous. So this one is, okay, the dangerous one. Do you think there is any treatment? No, there is no treatment. Just what you can do is genetic counseling. That's it. You will do genetic counseling to such families, tell them it's a gene disorder, be careful when you have a next baby. And nowadays, they are considering doing gene therapy and stuff like this, but onset 2 to 5 years, bedridden, they become bedridden by 12 to 20 years, they die around 18 to 20 years, right? So this is how it goes. So we give genetic consultation. Female carrier, male sibling, half have chance to be the sufferers, and female siblings, half can be carriers. You know how it goes, right? Treatment, glucocorticoid significantly slow progression of DMD for up to 3 years, and gene therapies are being considered, but not there. So again, like this thing. Now guys, I would like to talk about the other one that is called as Beckers, okay? That is called as Beckers muscular dystrophy. Now, if you know, like Duchenne muscular dystrophy, the Beckers is not difficult for you guys to understand. Simply, if you know how this one present, so the Beckers muscular dystrophy, MD, okay, I'm just writing MD over here. So muscular dystrophy. So again, this one is X-linked recessive, okay. So again, if anyone don't know, guys, please see what is autosomal dominant, what is autosomal recessive. Okay. Now, First of all, this is 10 times less frequent, less common, you can say, than the Duchenne's one, right? So this one is 10 times less common. Okay. So this is the first of the thing. This is 10 times less common. Now, this one again results due to the same dystrophin thing, right? The gene which is responsible for Duchenne, uh, but this one results from allelic defects. So you can say in this way that they produce dystrophin but not enough. Okay. Now I will tell you one point. Beckers resembles Duchenne. Okay. Beckers resemble Duchenne. It's a allelic defect. There is dystrophin but not enough. So everything will be there. Okay. They have proximal muscle weakness. They have pseudohypertrophy. They have hypertrophy of the calf, or like pseudohypertrophies will be there, right? But symptoms or the weakness start from 5 to 15 years of age. Okay. Mostly can be even later than. So simply at the time when the Duchenne people, they are bedridden, you will find these people walking around. Okay. Like typically speaking, Duchenne's, by 12 years of age, they will be bedbound or wheelchair bound. Okay. So Beckers, you will find them moving around. And most of the patients, they survive until 40s and 50s. So they have a longer life span. Okay, rest everything is same in these people. Again, the heart will be affected, and the lab findings will be same as well. CK, LDH, same thing. Biopsy, whatever you are doing, you will be doing this one. EKG findings or ECG findings, all these things will be present, and genetic uh, diagnosis will be there. Everything. Okay, like all these things will be same. There'll be no difference, guys. But simply in one there is no dystrophin, and second there is a little dystrophin. So this is the only difference between these two. So D for dangerous, D for Duchenne, right? So rest, everything will be same. Even the treatment will be same. Okay. So this is how they present. Now, what I wanted to talk about is myotonic dystrophica. Okay. Myotonic dystrophy or dystrophica, whatever you like you can call. Now, this is again a very interesting kind of condition, guys. Simply, like in our genes, like in our chromosomes, there are genes, and the genes, they are made up of what, like repeated nucleotide sequences, right? They have basically unstable trinucleotide sequence. Basically, CTG is the sequence which is too much repeated. Okay, so this one is basically located on chromosome number 19. Chromosome 19. Okay, this one is located on chromosome number 19. Okay, and basically when it is located on chromosome 19, it is basically DM1, And whenever it is repeated on chromosome number 9, it is DM2 or dystrophica myotonica 2. Okay, so this thing is important. So it's simply a trinucleotide repeat sequence, uh, unstable sequence is there. And what happens in these patients is simply they have too much trinucleotide repeat of this one, CTG unit, and simply when it is there, so they present with some, what you can say, uh, some condition, okay, which is myotonic dystrophica. So it have two type, DM1 and DM2. DM1, like chromosome number 1, is basically dystrophica myotonica 1, okay, and whenever it is on chromosome number 9, it is dystrophica myotonica 2, okay. So now what happens is like the if the repeats are more, the symptoms will be more, or you can say the symptoms will be severe, right? So you can say a number of repeats uh, correlates with severity of symptoms, okay, as well as autosomal dominant. It's autosomal dominant condition. Now, why we are studying this thing? Because it is the most common uh, adult muscular dystrophy. Okay, so you will found like these people as adults. Okay, now guys, I will show you one photograph and like I will tell you. By the way, there is a very 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 nice way to remember the symptoms of this condition. Very 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 nice way. I will tell you that thing as well. This is how they look like. Okay, this is how they look like, and I will explain you about this one. So first of all, you can catch these patients easily just by the look. First of all, there will be ptosis. You can see ptosis. Number second, bifacial weakness. Bifacial weakness. Number third, frontal balding. See, frontal balding, or simply their forehead will be too big. Even the woman, if there is female, they will present in the same way. Okay, they have a triangular type of face. See, hanged face. See, hanged face, right? So they have a drooping hang type of face. Now, when we examine them, we found that the distribution of weakness in these patients is the distal muscles are weaker than the proximal muscles. Remember, in all the other myopathies, the proximal are more weaker than the distal one. In this one, distal will be weaker than the proximal one. And because of this, because they have foot drop, they have distal weakness. They present with foot drop and they have high stepping gait. One of the things why it is called as myotonica dystrophic or myotonia, okay, is simply myotonia is basically delayed relaxation of muscle. Okay, see, they have delayed relaxation of muscle. I will tell you how to remember this thing. When we shake hand with these people, they shake hand and we ask them, shake hand nicely, like gently, or try to press it. So when they will shake hand with you, it will be easy for them to grab your hand, but as they have delayed relaxation of the muscle, so it's hard for them to leave your hand. So it will feel like that someone who has who shake hand with you, he don't want to leave your hand. Okay, and one of the thing in myotonia is what, like, you can see that sign when we tap on their thenar muscles with a hammer, their thumb goes into contraction. Okay, okay, now they have cardiomyopathy. Number one, because of muscle weakness, they have hypoventilation. They developed cataracts. These are associations. Now they develop diabetes mellitus. They develop infertility, and their testes are small, or testicular atrophy is there. Okay, so These are the features. Now, if you want to remember dystrophica myotonica, DM. So DM for dystrophica myotonica, DM for diabetes mellitus, DM for dystrophica myotonica. So DM is for cardiomyopathy. Okay. So now the important thing over here, and remember DM, remember distal muscle weakness. Okay. So again, hypogonadism. So see, in gonadism, DM, hypogonadism, their testicular atrophy is there. They are infertile. So many things can be remembered in this way. Okay. And what is the name of the gene? It is DMK gene, right? So it is myotonica dystrophy. Like they are the same name. Myotonica dystrophica, myotonic dystrophy, or dystrophica myotonica. They are the same name. So DM. Okay. So what is the name of the gene? DMK gene. So myotonica dystrophica gene. So like this way, And from DM, remember dominant. It is autosomal dominant. So many things can be remembered by D or M. Okay, so like this way. So these are the clinical features of these patients, right? This is how they present. So the patient has difficulty in rapid relaxation in the tightly contracted muscles. There is contraction myotonia. Okay, there is percussion myotonia I told you when you will you can say hit the thin arm muscles with the hammer, they have percussion myotonia. You can see the video simply. Okay, so now this is the clinical features of these patients, right? How we treat them, there is no cure. Ultimately it will progress to death, and the deaths usually occur around 50 years of age. To manage the myotonia, we can give them phenytoin. Phenytoin can be given to manage their myotonia. So this is how these patients present. And it can present like in very young age, like at 5 years of age as well. And how we diagnose guys, they have a typical look, history, examination, distal muscle weakness, cataracts, diabetes, testicular atrophy, things like this. You will measure their CK levels. Maybe they will be higher or maybe they will be normal. And simply the diagnosis will be made on genetic testing. You will found CTG, trinucleotide repeats in their chromosome number 19 for DM type 1 and chromosome number 9 for DM type 2. So this is how they present. So we cannot do anything for these patients, of course. That is a bad thing. I told you phenytoin can be given simply for it's an anti-myotonia drug. That's it. And if they have some cardiac problem because they develop cardiomyopathy, so we can put them pacemakers. Okay, if they have foot drop, we can put them some orthosis like prosthesis to support them. So this is how they present. Okay, so this is that periodic paralysis, guys. As I told you, it's a channelopathy. You can see a male 30 years of age, sudden onset of generalized weakness for 1 hour. No headache, numbness, or sphincter disturbances. Arrived here at 4 a.m. Similar episode 1 year ago. Drink wine precedes attack. Physical examination, cranial nerves were normal. Weakness of all limbs, and so arms and the lower limbs, tendon reflexes are decreased. What is the diagnosis? Treatment is administered some oral solution. So basically, this is, I told you, hereditary periodic paralysis in which like they have some channelopathy. Okay, like there is a mutation in the ion channels for sodium, calcium, and chloride. So it's a ion channel dysfunction. So what happens in this one? It have autosomal dominant inheritance, and by the way, it's not so important. That's why I'm going a little faster. Males are mostly affected, and what happens like they have like attacks of paralysis, which stay for some time and then they go away. It provoked by exercise, fasting, and cold, and weakness of the limbs appear when waking up in the morning and resolves in 2 to 3 days spontaneously. Clinical findings: serum. This is serum. Um, so serum level of potassium is lower during attacks. Okay, EKG shows hypokalemic changes. I have the lecture of hypokalemia in diagnostics, and the patient remain asymptomatic between attacks. And how we treat: simply administer them potassium. Oral oral use can be given. That is, avoid hyperkalemia. So this is all the things, guys, which we had to discuss. The important one, of course, like there are other many dystrophies. One is facioscapulohumeral dystrophy, which I will show you now. You can see over here I was talking about. So this is generally a benign type of muscular dystrophy, and it is again chromosome related, and it is mild, it is asymptomatic, and wasting and weakness of the facial, scapula, and humeral muscles. It it due to this weakness, the patient, they have problem. For example, when you will ask them to whistle, they cannot whistle. When you will ask them to raise their arms above the shoulders, they cannot. And their biceps and triceps are very thin, and there is winging of scapula. You can see over here, right? And but this is like benign type, you can say. It doesn't cause much problems in the patients. So this is the thing. Now, what you can say, um, of course, like for this one, no treatment is available. Or like we can just stabilize the scapula if there is too much winging to improve the function. Like when we move our hands, our scapula play a role. So, guys, this thing, and as I told you, like we just have to discuss this thing: polymyositis and dermatomyositis, which are inflammatory polymyopathies. You are going to discuss this way, like study these things in detail in rheumatology. I can show you the case, for example, male 68 years of age. So see, it's an old guy, progressive weakness of the limbs accompanied by atrophy for 2 years, and EMG showing myopathic pattern, muscle enzymes are raised, muscle biopsy shows profound necrosis, regeneration, and inflammatory cell infiltration. So again, inflammatory myopathies can be any type. Okay. I will show you something now. For example, these are common inflammatory myopathies: dermatomyositis and polymyositis. So see, derma means skin, myositis muscle inflammation. Polymyositis, multiple muscles are inflamed, right? So yeah, basically, polymyositis and dermatomyositis, they are quite similar conditions, guys. This one, they are quite similar conditions. I will show you how they look like. Yes, very, very important thing. So what happens, like there is basically inflammatory cell infiltration which destroy the muscles, and the face and the hands are particularly involved, and they have rash over the face and the nose and around the eyes, you can see over here, and over the knuckles of the hands you can see the rash. So this is the most typical findings we see in this one. And the muscles which are involved, they are basically proximal muscles, neck muscles. Okay, so when there is rash, guys, it is, remember, it is dermatomyositis, right? See, dermatomyositis, because the skin is involved. So when there is skin condition is there, we call it as dermatomyositis, otherwise polymyositis. So this condition mostly develop chronically, and they have tender muscles, they have weakness in the proximal muscles, they have problem with bathing, with combing hairs, with standing up from low chairs, and all these things. And dermatomyositis is particularly a disease of old age. And one of the things to remember is, like, whenever dermatomyositis is present in the old age, we always scan them for malignancies, cancers, because many of these people, they have underlying malignancies. The good thing about this disease is, you know what? They respond very, very well to steroid treatment. Okay, they respond very, very, very well to the steroid treatment. So actually, there is no point. It's corticosteroids, you can see, the first line treatment. They are very effective treatments against them. So this is how we present, how we see the conditions and how we approach the conditions related to the muscles. And there are many others muscular myotrophies as well, But there's one thing called as myotonia congenita. It is also called as Thompson's disease. Same like channelopathies, It's like there is hypokalemic periodic paralysis, there is hyperkalemic periodic paralysis as well. So there are like many other conditions. I told you one of the thing, which are metabolic myopathies like McArdle's disease. So McArdle's disease, they have like some deficiency of phosphorylase deficiencies there. And so all these things but they are not so important. So that's why I'm not talking about them. Mitochondrial problems can be there. Mitochondrial muscle problems can be there. For example, I will tell you, just to mention this thing, I name two things. One is called as MELAS and one is called as MRF. So what is MELAS and what is MRF? Basically, MELAS is, M is for mitochondrial, E for encephalopathy. Okay, then LA is for lactic acidosis, and S is for stroke-like episodes. So that's why they call it as MELAS, MELAS. So basically, these conditions are basically, they have some biochemical abnormalities in their mitochondria. Remember, they start with M, the problem is in mitochondria. Okay. And if you remember, if you know how we inherit the diseases, guys, remember, we cannot inherit the mitochondrial problems from the father. So very easy to remember this thing, I will tell you. M for mitochondria. And remember, see, father just gives the sperm and the mother gives the egg. So the mitochondria are in the egg. So M for mother, M for mitochondria, and M is the name of the diseases, which are mitochondrial DNA diseases, you can say. So they are always inherited maternally. Okay. So one of the thing, they always affect the eyes, muscles, nerves, like this. Okay. So what is MERRF? Like, why they call it as MRF? So M is for myoclonic epilepsy with RRF is red fibers. Okay, so this is the appearance of their muscles. So that's how they describe. Okay, so this is like the mitochondrial diseases. So that's all, guys, about your neurology, and we had covered all the topics of neurology. Okay, not all the topics like what were included in your course, like we had discussed all of those. So thank you so much, guys, for listening.